We're streaming from beautiful Centennial, Colorado today. Thank you to everyone who's attending in person, and thank you to everyone online. We're here today to talk about MS with Dr. Enrique Alvarez. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen, Genentech, Novartis, and Sanofi. This speaker series is just one piece of our education programming. We have a variety of formats available, including both in-person and online options, with most of our programs also available on demand on our YouTube channel, which is just the MS Center. This is where you can find our most recent MS extension data and other MS research updates, as well as Sleep, MS, and Your Brain featuring Dr. Andrew Wolf. We also have a fun series called Topics in 10, where you can learn about specific topics in a short time frame. Our latest episodes covered Insurance Basics with Dr. Kavita Nair and Habits for Brain Health with me. The next event in this Q&A series will feature Dr. Ellie Wade on September 17th on Zoom. We announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. And now I'd like to introduce you to Dr. Enrique Alvarez. Dr. Alvarez is our medical director at the Rocky Mountain MS Center. He's a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at the University of Colorado in 2013 and is now the director as well as the vice chair for clinical research at the Rocky Mountain MS Center at University of Colorado. We had a lot of great questions submitted today. I do mean a lot. So we will get to as many of them as we can. We will be grouping similar questions together. So if you don't hear the question in just the way you asked it, just listen for the right topic. And again, you can ask the questions by typing them in the chat or raising your hand here in person. All decisions regarding your MS treatment and medications, though, should be discussed with your neurologist. And with that, I'll turn it over to Dr. Alvarez.
Awesome. Well, thanks a lot for coming out, guys. Appreciate it. There's a crap load of questions here. So, but you guys made it here in person, so I will make sure. So for those that haven't made this, this is just a Q&A. So I have my marching orders. So if you guys don't have anything to start us off with, I'm happy to kind of follow up with these, but I'm happy to start with you guys and see if you guys have any questions. No. All right. Sounds good. If things come up, feel free to chime in and ask them. And you guys might have submitted them earlier, might be part of this. So I usually try to kind of think about this sort of in the way that we tend to think about how, you know, if I was giving a lecture and how to break it up. So I'll talk a little bit about sort of disease-modifying therapy, sort of drugs. There weren't much questions around diagnosis, which I'm actually getting ready to present on for Wednesday. So in 2 days for our grand rounds, because it's actually going to be changing quite a bit. So it hasn't been officially published, and once it is, I'm sure we will have a webinar to kind of talk about sort of the diagnostic criteria and how they're changing. I'll give a few highlights. They're changing a fair amount. So usually we've been having these little incremental things. And it's like, oh, this new version now includes that if you get an MRI and there's a new lesion now, we can call that a clinical event. Or if there's an enhancing lesion and non-enhancing lesion, that's an active event and a non-active event, and we can call that MS. So it's been like you get one tidbit and that justifies an upgrade. There were at least 10 upgrades on these new criteria. So we're still digesting a lot of it. And they met in 2023, it's 2025, they haven't been published yet. So that tells you a little bit about how complicated they might be. I'm hearing that there might be 5 papers involved in trying to get this thing out there. There's going to be a lot of details. The general gist is they're adding in a lot of new MRI criteria. They're adding in the optic nerve, which is probably the biggest change. 20% of patients get diagnosed with an optic neuritis. So for it not to be part of the criteria in the past seemed kind of ludicrous. So they're rectifying that. They have a lot of criteria as to how to look for that. There's things that are going to be kind of coming up called the central vein. So that is adding specificity to some of the lesions that maybe we might not have considered as MS lesions that we can maybe say, hey, this looks a little bit more concerning for expensive, although maybe they're more expensive. So you have to look at them in magnetic rims or basically a dark rim around them if you get the right sequences. We don't do a lot of that yet, so it's a little bit tricky. We're hoping to get those up and running in a couple of months because they might help us as we start talking about a new drug that may come out later next month called tolebrutinib. And it looks like those patients who have those might respond to that drug a little bit better than other drugs for progressive disease. And surprisingly, there wasn't any mention about those drugs. So we've been doing a good job, I think, of doing updates as we learn about them. We will talk more about it. The last education summits have had a lot of information about the BTKs and sort of how to look at it. So I think the information is out there. There hasn't been anything new since really about a year ago now. So we'll learn a lot more about those as they come through. Then there was a number of questions sort of around treatments. On the treatment front, there was a lot of discussion around sort of switching drugs, starting drug, and it'll talk a little bit about progression and relapses. So before we talk about too much about drugs, I think it's important to kind of maybe spend a few minutes talking about some of the terminology. And I know for people that maybe come to my events a lot, I tend to go through this, but I think sometimes it's a little bit hard because the terms that we don't use very well, and it can be a little bit confusing from that perspective. So when we talk about MS, I like to think about it almost as two diseases. There's the relapses, which can get a little bit confusing with pseudo-relapses. So relapses are events that look like bruises. So like if you fall, you develop a bruise. It might take hours to a day for that bruise to swell up. Symptoms develop over hours to a day or two, and then they kind of gradually get better over days and weeks. And that's kind of usually what we tend to follow. These are the things that classically, when we look at MRIs, produce the little white spots, or sometimes not so little white spots on MRIs. And so when we're trying to kind of look at that, that's the inflammation that those drugs are good at. And when we talk about inflammation, there's different types of inflammation. It's important to kind of try to keep that in mind. So some drugs work well on some type of inflammation, some not so much on others. Tylenol, for example, works a little bit better on fevers. Ibuprofen might work a little bit better on sort of acute pain and other things like that. And so kind of like that for the MS drugs. There's drugs that work really well for relapses, and there's drugs that maybe work better for progression. We've not had examples of drugs that work only on progression. So basically everything we've done has primarily focused on relapses, the little white spots, and those kind of aspects of the disease. When we talk about progression, it's very different. That's slow, gradual decline in things. So if you think about, if you know somebody with a Parkinson's disease and Alzheimer's disease, these are changes that happen much more in the order of like months, more like months, like years. You know, last year I could do this, I can't, we worry about, because usually it's not progression. There might be other things that happen in MS. The big one has been PML, you know, a brain infection that we've talked a lot about with our drugs. We're talking less about it, but it still comes up. It came up on some of the questions, so I'll talk about it a little bit later. But it's one of those things that tends to develop over months, weeks, 1 or 2 months. Tumors develop over weeks to a few months. So how fast things kind of develop, how fast things change, tend to kind of give us clues as to what's going on and what's causing things. There's also, when we talk about the timing for a relapse, and we talk about pseudo-relapse, those are things that they can look like a relapse. They can look like those symptoms that kind of come and go, but they're not driven by inflammation or little white spots. The inflammation is the stuff that works well for steroids, plasma exchange, and things like this. But sometimes an infection, not sleeping well, hot outside, dehydrated, stress, and all kinds of things like that can kind of bring out those old symptoms. So those pseudo-relapses, they're real symptoms. They're just not driven by that inflammation, by that drives sort of those bruises in the brain. That stuff, we normally say, hey, it's got to last more than 24 hours in order to be a relapse and things like that. But really for that stuff, it depends on what's bringing up those symptoms, right? So if you're outside, you exercised and something comes back, you went for a walk and you start getting a foot drop or something like this, that will get better as soon as you rest, cool down, get some sugar in you, those kinds of things, right? But if it's because of something like COVID and it's bad COVID, those symptoms aren't going to get better too. And so those symptoms are going to last, take that time to kind of fix it. And the solution is to try and fix whatever's causing it, right? It might be chicken soup, it might be cooling down, it might be rest, it might be sleep, it might be, the chill pill, if it's anxious, whatever, that kind of works. But the idea is to try and kind of go after what's causing the problem. That's going to be important for that. So in the past, we talked a lot about B-cell depleting therapies. We've used them a lot. Those work really well for relapsing disease. They do a little bit for progression. This new drug, tolebrutinib, does a little bit, maybe more for progression, maybe about on par with the B-cell depleting therapies, but it's different, so we might be trying them. But it doesn't look like they do a lot for relapses. So if you're at risk for having relapses, and remember, we all got diagnosed with little white spots in the brain, so you had a relapse, even though you may not have had symptoms associated with it, then we need to be worrying about that. One of the things that we know about that inflammation with the little white spots is it's much more common when you're younger. You have a healthy immune system. As you get older and things kind of sort of stop working quite as well, one of the things that stops working quite as well is the immune system. So that applies for relapses. And so there was a lot of questions talking about, I'm hearing that around age 55, we stop drug. Maybe. I personally tend to like 60 or 65. The clinical trial that Dr. Corboy did looked at age 55. The person that broke through on that trial with MRI lesions and everything else like this was 55. So we're kind of maybe pushing that up a little bit. The average age in that study was about 58. There was another study that was 48. When people broke, that trial got stopped early. So if you're 60 and getting diagnosed with a new relapse, by the way, that's about 5% of MS patients. So it's not super uncommon for that to be the case, right? 1 in 20 is getting diagnosed after the age of, if I did my math right, after the age of 60, right? Then you would want to continue treatment for some period of time. Okay. So how long you're stable is an important factor. I usually like 5 or 10 years to kind of be stable before we start to talk about coming off drug. There was a question about, I got diagnosed at age 61 and my doctor doesn't want to start drug. I don't know the details of what type of MS that is, but it's important to recognize, is it progressive MS or is it relapsing MS? If it's progressive MS, and maybe sometimes we've had MRIs for headaches or other things like this, and the MRI maybe hasn't changed in 5 or 10 years, but the symptoms started to develop 5, 10 years ago, and it's primary progressive or say progressive disease, and this also happens to us a lot. Maybe it was an optic neuritis, not treated 20 years ago, and now you're starting to have some new symptoms and getting diagnosed with kind of a slow, gradual decline in function. You might make that diagnosis at age 60 or 61. But if primarily what you're going after is progression, what we know is that B-cell depleting therapies don't tend to do much in women who are older. So they tend to work primarily in people who have a lot of inflammation. So it's younger people. Men tend to have more inflammation than women. They don't get MS as often, but when they get it, it tends to be a little bit worse. And so trying to kind of understand where you're at, that probably influencing it. If you're getting diagnosed with a relapse at age 61, probably would be recommending drug. So that's a little bit about how I think about the disease when I think about sort of, stopping drug, kind of the effects around progression. There were several questions around sort of that progression aspect of things and getting diagnosed at different ages that I think kind of get clustered up in that. For switches between, there was a question about switching between Tysabri to B-cell depletion because of PML, that brain infection. So the way I think about PML is it's a disease that we understand much better now than I think we did 10 years ago, 15 years ago, as far as the risk from these drugs. And the reality is that all of us have the virus. So why isn't the blood test positive? It's because it tests for antibodies against that. And we all have antibodies, but it's kind of trying to measure how much of the antibodies you actually have. And the thought is that the higher the level of antibody, that the more chances that the virus is actually active in you, and then it can mutate. When it mutates, it can go from being a bladder virus to a brain virus and cause the infection. And if you have a drug that prevents the drug from, that basically blocks your immune system to fight that virus, then that's where you run into problems. So you want to avoid having a high titer on drugs that we know really prevent the immune system from getting into the brain. Tysabri does that to a T. So you can be on drug if you're JCV negative. And again, what is can be and can't be, right? This should be kind of looked at more in context of what is the risk? What's the risk you're willing to take? We have other drugs that maybe have less risk, so we can talk about sort of maybe preferring other drugs. In the old days, when Tysabri was the main good drug around, if you had bad disease, you took your chances with PML because your chances with MS really sucked, right? Now we're putting people with fairly mild MS sometimes on some of these drugs, so the risk of the virus is worse than the risk of the MS. So we have to balance these things, and it's not the same for everybody. And so coming up with guidelines of saying like, I stop everybody at age whatever. I, switch everybody from this drug to that drug. Again, you have to kind of put it in context for each person. It is complicated. For PML, the risk goes like this. On Tysabri, if you're JCV negative, the risk we say is less than 1 in 10,000. It doesn't matter how long you're on drug, so being on drug longer doesn't matter. If you're positive, the longer you're on drug, the more chances for mutations of the virus and the more chances of developing PML. So time matters if you're positive. If you're negative, not so much. Now, you can go from negative to positive, unfortunately. That happens 1 to 2% of the time per year. So you're constantly having to kind of check that. We check about every 6 months or so and make sure that it's still continuing to be negative. You can take a little bit of time to switch people if you have to. It happens to us every year. We have somebody that converts over. And it's no big deal, but we just want to make sure that we're moving and kind of rebalancing that risk and the benefits associated with that. There's a risk of PML with B-cell depleting therapies. That risk at this point is about 1 in 100,000. So if you're going from 1 in 10,000 to 1 in 100,000, it's a tenfold difference. If you like the drug you're on, the chances of crossing this street and getting run over is probably higher than your chances of developing PML, or higher. Anyway, you get the analogy. So, are you never going to go outside? Are you going to be careful about it?
We had a question online. Is there an impact measure if the JC result is indeterminate?
Yes. So it's a commonly misunderstood test. So on the value scale, if it's a 0.2 to a 0.4, it's indeterminate. Then it goes to another test, and that test will determine if it's positive or negative. So there's nobody who's indeterminate. Everybody will have a positive or a negative. The reality is that the risk doesn't really go up until you're at 0.9, 1.5. So sometimes for people who are really benefiting from Tysabri and haven't done well on other drugs, we might keep them on. We might do more testing. We might be monitoring much more closely and kind of keep a closer eye if you're in that lower range. So that's how we do it. Some places are like, we'll do MRIs every 3 months, and that way if you have PML, we'll catch it early and we'll deal with it then. We try to prevent things, not deal with them when they happen. So that's the other question. The other question was around switching from B-cell depleting therapies to Tysabri. Very little concern, especially if you're JCV negative. If you're positive, we worry about the risks we just went through, about sort of those risks and things like that. All right, that was a really long discussion about that stuff, right? So for those that have a short attention span like me, usually we'll talk a little bit about just some quick hit type questions unless we have any questions from the audience. And I can ramble for an hour and a half, so trust me, don't test me because I will go for an hour and a half.
Okay. Hey, come Okay. So on the note of sort of B cell treatment and the treatments that deplete the B cells, what is your response to somebody who says that it causes cancer? Like, because I've heard that a lot, and I don't quite know. I'm not educated enough to say I don't believe it does, but I know it was a cancer treatment of some sort.
Perfect question. And there's a couple, I think, in here as well regarding that, so that's perfect. The concerns for breast, so to take a step back, I was not around at this time, but I'm being told that in 93, when the first drugs came out, the interferons, beta-seron in 93, came out, that there was talk about cancers with these drugs. You lower the immune system, they help fight cancers, that the risk of cancers were a thing. So we've worried about cancer since day one with our drugs in MS. We have not seen much in the way of signals with them, so we felt pretty comfortable, but we've monitored them for all eternal time. Ocrevus during the clinical trial programs on the phase 3s did see a number of breast cancers. So that's kind of what raised the alarm bell for a long time. When things don't happen very often, it's hard to say what's the chances that in a trial with 1,500 people or large numbers of people, how many of them would develop breast cancer? So, and what it came out for breast cancer is in that range, when they compared it against big databases from like countrywide registries, is that that number came just under that range. So we've monitored them that, and over time, it's kind of come back down into the middle range, into sort of what we call the median range. The problem with breast cancer a little bit is that when you look at the population that's being studied, 3/4 of our participants in trials are women. I don't remember exactly the number for the Ocrevus trials, but you can guesstimate it's probably 3/4. Under the age of 55, so you start removing all the colon cancers, lung cancers, and all that kind of stuff, right? What you're left with is primarily breast cancer. So you're going to see breast cancers be a common thing, and the most common cancer associated with those drugs. We have not seen it with other drugs, again, that jumps out over what we would normally kind of expect. And so I think it's one of those things that I think you have to monitor it, you have to be careful. And then you kind of say, yeah, I'm again more worried about my risk with MS than I am from those drugs. And if that's not the case, then you choose drugs that maybe are associated with that a little bit less. It may not work for MS quite as much. As you get older, that risk of cancer goes up. You might want to choose drugs that maybe aren't as effective. And that's where a lot of the discussion of risk balance goes, right? And as you get older, we talk about stopping drug, de-escalating drug to drugs that don't lower your immune system as much and let you help fight those cancers. The other drug that's been associated with cancer a lot has been Mavenclad or cladribine. That drug took for forever, kind of got stopped, and then it kind of got brought back together because there were a number of cancers seen Those were kind of all over the place. It is kind of a chemo-light drug at full doses. It is chemo. It's definitely working as a typical chemo drug. The nice thing is you can kind of do it and not have to maintain it for a long time. And so there was a few questions about, if I have cancer, can I do this, do that? The tricky part around looking at drugs and cancer is trying to figure out what is the treatment for that cancer going to be. Chemo works really well for MS. Brain radiation works really well for MS. The safety stuff is not so great. Radiation usually takes a big hit on brain volume, usually on several percent orders and things like this. So we try and avoid those drugs as much as we can. But if you need it for a cancer, then that's great. And it usually buys you 2 to 3 years where you don't need an MS drug to kind of get restarted. However, we're getting fancier in how we treat cancers. And so sometimes for a lot of breast cancer, for example, we're using hormones, and so if you use hormones, that's not going to do anything to your immune system. So for those types of chemos, we still need our drugs on board. So it's getting a little bit complicated. For some drugs, we really worry about them because the way they work is to boost the immune system. So for melanoma, some lung cancers, and those drugs. So if they boost the immune system, you can expect going to do for your cancer versus God knows, right? But that's the balance that we have to make up, right? And that's why they call it the art of medicine, because it's a lot of making it up a little bit as we go sometimes, right? We try and kind of piece it together a little bit, but that's kind of what we're left with. That was a long answer to your question, but appreciate it. Cool. Any other questions?
I do have one from online.
Yeah.
What DMT would be used for spinal cord lesions, and what generally causes them? Is it inflammation or relapses?
Yes and yes. So spinal cord lesions, if we see a lesion, it's a bruise, it is a relapse, it is a lesion that's caused by inflammation. So all those would be there. You might hear the term transverse myelitis. Transverse just meaning across. I'm not sure why we throw that word in. I guess myelitis was too short and we needed to make it fancier. Myel, M-Y-E-L, is spinal cord. Itis is just inflammation. So it doesn't tell you what's causing that inflammation in the spinal cord. So you can have a transverse myelitis from a slipped disc and many, many other things. One of the common issues is MS that can kind of do that. But I think that answered that question. Did I get that one? Then correct. And no specific DMT for that. We worry when we see spinal cord lesions because a lot of spinal cord lesions tend to be associated with symptoms. So it's about 50% of spinal cord lesions tend to give you symptoms. There's a lot of information that goes, and so we tend to kind of be a little bit more aggressive in how we treat patients that have a lot of spinal cord lesions, or where the MS primarily seems to affect the spinal cord versus the brain. Not to say that the brain's not important, but one of the weird facts about MS is that only about 5% of lesions in the brain tend to give you symptoms, which is why by the time you get diagnosed with MS, there tends to be, on average, 16 or 17 brain lesions present, because so many of them are not associated with symptoms. Sorry. There was a related question that I want to address real quick. Somebody brought up the idea of a monophasic, meaning a one-time, one-time lesion only, specifically of something called a Balo's lesion. Balo's lesions, one of my colleagues gives me a lot of crap because he says I can find a Balo's lesion in just about everybody. That's not quite true. But they're very unique lesions specific to MS, as far as I'm aware of, where they have rings around them. So it almost looks like a tree trunk. And when you look at these, there'll be rings of lesions with normal areas, and another ring, and then another ring. And sometimes you'll see rings of enhancement that kind of go with it. The way we think about those lesions is that there's areas where you have demyelination and then repair, and then remyelination, and repair, and they kind of grow from inside out as the lesion expands. Why it does that, nobody knows. But that seems to be a little bit of the case. Because MS starts with multiple, the foundation is that you need to have multiple things to be MS. So a single thing can't be multiple. So we might call it single sclerosis if you want to, but a lot of times single sclerosis stuff just doesn't go on to MS. If you look at optic neuritis, and in the past, this is why a lot of times, to go back to discussion from earlier on, about 20% of patients have optic neuritis, and you might end up with somebody that has vision loss and they do nothing for that. 20% of patients with an optic neuritis do not go on to develop MS. Now, we can use MRI, and if you have more than 2 lesions that look like MS, that number goes up to 50%. If you have positive spinal fluid, that number goes up to 80%. This is why the new criteria adds all these extra stuff to it, so that, you know, it doesn't take as much stuff to diagnose MS and wait for you to have tons and tons of lesions to do that. So a lot of times with single lesions, whether it's a Balo's, a spinal cord lesion, transverse myelitis, a lesion of the optic nerve, or an optic neuritis, we wait and watch. Especially if the other MRIs look good and there's nothing else there, then that allows us a little bit more flexibility to kind of say, let's wait and watch, because the chances are you may not go to develop MS. That 20% becomes 10%. So it becomes very unlikely then to go on to MS. Another question.
We had a circle back question.
Associated with a bunch of different random ones. The newer trials didn't show that it actually resulted in any cancers. So you just do end up doing age-appropriate testing, which the guidelines change every year, and I don't know them, but usually it's like, you know, mammograms at 40, I think now, colonoscopies drop to 45, yearly skin checks for pretty much everybody. That all changes if you have a family history of that type of cancer. Yeah, talk to your primary care provider.
Who is the group specifying the new criteria for MS?
There was an international consortium. They did a really nice job. It included over 50 people. I got to meet in Barcelona, so I'm a little bit jealous. They had all 5 continents represented. I think 2/3 were still men, but it meant that usually in the past it was like 1 woman in the group. So 1/3 of them were women. And there were good discussions around sort of managing around Hispanics, African Americans. So it actually was sort of I think the first real consensus group that met together that looked at MS as a whole and not just a white European disease, which it was kind of the case in the past.
Did I hear correctly for optic neuritis is a more prominent symptom for Hispanic patients?
More common in Hispanics. Again, unknown reason why this might be the case, but that seems to kind of hold, at least in a couple of different studies. Also more common in younger people in certain diseases. So there might be something about a young immune system versus an older immune system. There's some discussion as to in mice, like where you kind of trigger the mouse MS, so you can whether or not it's MS or not. There's arguments about that, but depending on where you kind of do the injections, where those learn a lot about the biology of it.
And the effects of creatine on MS brains.
So creatine has come up a lot in the last 2 weeks. I don't know if there's some article that's come up that I don't know about, but I learned from you guys. So as far as I know, there's not much about, but I think it came in the context of around especially menopause and trying to keep up memory function is sort of like some of what some of the patients were telling me about. It's hard for me to imagine why that would be the case, but we'll have to look at the studies and kind of see. So on that line of things I've never heard of and questions that get asked to me, I will continue with a couple of other ones. I got asked about Nervive, so I looked that up, and it includes a host of vitamins, including alpha-lipoic acid and B vitamins. Alpha-lipoic acid ended up not helping for MS. There was a big trial. It actually got halted for a little while because of more what the stuff was mixed with and the alpha-lipoic acid affecting liver. So it also doesn't seem to be hurtful. And if you're deficient on B vitamins, it could be a good thing, but most of us are not deficient in B vitamins. So it's one of those things, probably does help. You feel like it helps, go for it. I'm cool with it. There was a question around, what was the other one? There was another drug used for pulmonary hypertension that I'm not aware of any connection, but supposedly it might have got suggested that the cardiologist had said it might help. And I cannot.
Remodulin?
Yeah, Remodulin. Not sure. There was a question about probiotics. Probiotics is an interesting one. There occasionally are bacteria that are associated with MS and some bacteria that are protective in the guts. The problem with a lot of these studies is that associations don't mean causation, right? So it could be that if you are eating a healthy diet, you promote certain bacteria. And if you're eating a healthy diet, you're probably going to do better from your MS. And so whether or not, that's a good bacteria from an MS perspective, or is just kind of overall helping with general health, that's an important thing. So probiotics, for the most part, aren't necessarily associated with good or bad things in MS. However, if you have a lot of infections, right? So urinary tract infections are common. If you're putting on antibiotics and you're destroying your gut bacteria, your gut usually doesn't like that very well. So probiotics and putting in good microbes in there can be helpful to kind of just help you digest food and things like this, right? The analogy a little bit, for good or for bad, means you produce a lot of beans routinely, you probably don't produce that same amount of gas because you develop bacteria that can break them down much more efficiently. So we all have these shifting cultures in our gut, and we feed them and they feed us in return. It's a very symbiotic thing. And just remember, there's more bacteria in your gut than there are cells in your body. So there's a lot of things in there that are helping us and sometimes hurting us. So I think for probiotics, it's one of those things that they can be helpful. I think it's important just to kind of think about, maintaining gut health, but usually it's maintaining good eating habits, and goes back to the wellness. If I had one word to say, to do, is just do wellness in all its shapes and forms, right? Exercise, be a good weight, don't smoke, like all the things that we know we should be doing, and some of us suck at them a little bit more than others. So those are the things that I would kind of talk about. I'll talk a little bit about osteoporosis. I got a question about, I was on a lot of drugs, I was diagnosed with osteoporosis, were these drugs associated with it? It ties in a lot because we talk a little bit about vitamin D and sort of the importance in MS and some of these things. So in the past, we had a big association of osteoporosis in MS patients. Number of reasons for that. We didn't have drugs for MS. We got steroids in the 60s and 70s. Steroids are not good for bone thinning. So the other thing that we know that helps bone health more than anything else is weight-bearing exercise. If you're in a wheelchair, have difficulty with mobility, your bones will not get built up, they'll get weaker. So we recommended a lot of calcium because that's the thought that vitamin D actually is helpful. Foods that don't, we always think about milk and things like this. That's great. There's a lot of calcium in fruits and vegetables and stuff like that that also and you can absorb all the calcium you need from all your regular foods if your vitamin D is okay. So how do we get vitamin D? In the past, it wasn't a problem. We wore little clothing. We spent a lot of time outside, and we would eat the whole animal. And we all ate animals because it was survival. And so you ate the liver. So liver has huge amounts of vitamin D, and that would normally get you from a diet perspective. And then from sun, with little clothing, no sunscreen, you would get it from the sun. So you can make pretty good amounts of vitamin D, impressive amounts of vitamin D to kind of keep us healthy. We wear clothes, we use sunscreen, we spend a lot of time indoors, we don't get it from sun. And last time I checked, I think I've had 1 or 2 patients at most in the last couple of years tell me that they eat liver on a regular basis. Hence, most of our patients have a vitamin D level that's through the floor. And so that's why we recommend take vitamin D. Vitamin D actually turns out can help reduce the number of attacks for MS. There was a big ginormous study out of France, finally well done. It's impressive they were able to do that trial because it was placebo controlled, and there were still a lot of relapses with vitamin D, but there were less than the ones that were on nothing. So it does a little bit of something, be on something that will really stop you absorb the calcium. It'll help prevent that osteoporosis as well. And if you do wellness, you should be covered. All right. Big next topic I'll talk is pregnancy and babies. Lots of questions about pregnancy. So what's the data? What are we doing these days? I know, probably not in this crowd, right? It comes a little bit on the side of, should I be considering kids from a genetics perspective, which is another question. But let's talk drugs around this first a little bit. So as neurologists, we tend to be very cautious. So our first answer was, don't take drugs during pregnancy. We often would say, don't get pregnant, and those kinds of things. There was a lot of notions that pregnancy cured MS, and so you'd see, a lot of babies sometimes being born as well. The answer is somewhere in the middle. So there are drugs that we now know are pretty dang safe during pregnancy. That includes Copaxone, for example. Copaxone is a drug that you inject, and it breaks down at the skin level. There's no drug levels to the drug. It cannot get to baby. It will not hurt baby. That has not been recognized up until that recently. So in the past, you would still have a lot of debates about these things. But Copaxone is safe. It's just one of the lower efficacy drugs. So Tysabri has been used during pregnancy. It's probably a pretty safe drug. Babies can sometimes be born with a little bit of an anemia. Now, it tends to be really minor and not a big deal. So a lot of times what people have done is stop doing it towards the end of the pregnancy, with the idea that you weren't allowing for a lot of rebound to happen by stopping drug early. And Tysabri is one of those drugs that has rebound associated with it, meaning it controls the disease, but 2, 3, 4 months later, you start getting this surge in disease activity. It is not great to be treating in the middle of pregnancy some rebound. And so when we've looked at it in our institution, and Anna Shah now is an expert in this area and has looked at over hundreds of pregnancies at our institution, the number of attacks through Tysabri is through the roof, primarily because people stopped their drug and allowed for rebound. So if you continue them or stop them at the very end, it does much, much better, and it can work as a really pretty good drug. What we've done a lot is B-cell depleting therapies. We love them for this reason. We know that the infusions that we do, especially like every 6 months, we started during the pandemic extending them out to, 9 months, 12 months. There was a few trials that kind of had extended stuff. The phase 2 rituximab trial got a single dose, split, double dose within a couple of weeks. So really one course of drug and nothing for a year. And patients did really well throughout that entire year. 9 months fits into 12 months really well. So if you do the math, it works out pretty good. And so people would time around it, and the windows around the infusions just kind of kept getting bigger and bigger because it's hard to schedule making it. right? So if you're trying to kind of say, hey, go at it, it just puts a lot of pressure and it doesn't work very well. So we started kind of expanding those windows and things like this. And now we usually kind of say, hey, maybe a month after an infusion, just start trying, stop a few weeks before the next infusion, so you know you're not pregnant by the time you get the nice window for that. With ofatumumab, the once a month option, we now kind of time it so that you kind of do a shot the day of the period. If you have a period, you're not pregnant. So it kind of, if you get pregnant, then you stop doing your infusions for the pregnancy. And that kind of gives you a really nice tight window to kind of do that. That's just hard to time with an infusion since it involves other people. And so that's allowed us to actually have really, really awesome outcomes over now, I think, over a couple hundred pregnancies in our institution. So what do we do afterwards, right? So we talked a little bit about pregnancy as a cure for MS. The number of attacks actually goes down throughout pregnancy. It goes down to about half by the time you deliver. So it's not a cure, but it does cut the risk in half. The problem that we often forget about is that 2 to 3 months after you deliver, the risk actually shoots up to about twice what your normal risk would be. So we want to have something on board for that peak. And that's what allows us to do the infusions, you know, even while breastfeeding, a lot of times with those antibody treatments. Now, we try to wait a couple of weeks after you deliver because the baby's stomach hasn't quite developed, and so it can absorb those antibodies. But an antibody is just a big protein. So after a few weeks, it'll just chew up that drug. You know, otherwise we'd give you the infusions not by infusing, then we'd just give you to you in a bottle, and you would drink your drug, and that would be the end of it. But no, your stomach chews it up. And so baby will chew it up. And now we've looked at in 10 babies, and all of them had normal levels of B cells. One had slightly normal, slightly low levels, but had the B cells. And so that's important because, you know, babies get a lot of vaccines even with breastfeeding. So that addresses sort of pregnancy, lactation. Wow, we're cooking through these. Was there one other one online?
I do have a couple of follow-up questions.
Okay,
here.
perfect.
Okay. When you spoke of vitamin D, what's the ideal number to achieve?
So at least 30 from the Endocrine Society. The upper number is a little bit trickier. We're shooting for a number around like at least up to 80. We used to say 100, but what we started to kind of notice is that people with higher levels, so vitamin D helps you absorb calcium. If it's too high, then you start to pee out calcium. So too high levels is dangerous as well. We don't want to kind of get rid of that. So that's kind of the number we tend to shoot for.
You mentioned kind of the cancer risk specific with Ocrevus. Are you seeing the same thoughts with Briumvi?
So we look at them with all B cell drugs, but so far that number hasn't really jumped out with any of the B cell drugs. So Briumvi, ofatumumab, rituximab, or really Ocrevus at this point.
And then do you see people with MS who also have IBS?
Yes. It's a common disease. We see a lot of patients, so we see a lot of patients. It's not necessarily associated with it, which maybe I can transition into genetics a little bit. You often will hear the comment of like, oh, it's an autoimmune disease and we're prone to autoimmune diseases in our family. There's really not been a lot of autoimmune likes to study ankylosing spondylitis with Spawn will have ulcerative colitis. We don't have those associations. In the past, we've said maybe thyroid disease. Thyroid disease is a common disease, and so it's maybe common just because it's common. But when you kind of control for everything else, it didn't really kind of pan out too much. Genetically, the closest disease, if I remember right, was psoriatic arthritis. Which is part of the reason that I think they looked at Tecfidera, because originally it was being used for that in Germany as a monoclonal, as a compounded drug. And it worked in MS, but I don't see a lot of patients with that in our patients. So I don't know that that association really kind of holds up much. And so we don't tend to see a lot of other genetic conditions associated with MS. The question that I got posed was, there are hundreds of genes associated with it. There's no single gene associated with MS. From a baby perspective, they are at increased risk. So the risk drops off really fast. First degree relatives, so kids, brother, sister, parents probably less likely because they're older. So if they would have developed MS, they would have likely developed it by then. Have a tenfold increased risk of developing MS. If you're an identical twin, that number can shoot up. So genes are important. They're not the full answer. By the time you get to 2 degrees of separation, like a grandparent, that risk is kind of the same as in the general population, which is about, I use round numbers, 1 in 1,000. People might use 1 in 400, 1 in 500, 1 in 600, and things like that. So tenfold above that would be 1 in 50 or something like that. So it's increased, but the chances of developing MS is still maybe 1%, 2%. So pretty low. So if you're thinking kids, have kids, we now have good drugs. Let me see if there was some other question about the genetics associated with it. Yeah. Yeah.
Okay, so as far as probabilities of getting MS, I know that there's a lot of speculation that, like, especially at the Colorado latitude, it's higher probability for people to get MS here or along this line. Has that really been scientifically proven? Is that something that's just sort of an old wives' tale? I cannot remember because of my wonderful MS brain.
Yeah.
So could you go into that for me, please?
Yeah, so there is, for the latitude, so how high up from the equator we are, there is more MS in Colorado than a lot of the surrounding states. I trained in Missouri, and I would say the literacy around MS is vastly different. So I think that probably contributes to it. It's also a very white state. So I think the risk might be a little bit higher. I don't know about altitude. There's some discussion around some of these things, and it could be just the genetics around these parts kind of isolated some out. Although we have so many transplants that I think could be hard to kind of say that that's probably sort of the real reason for it. It's a very healthy Colorado, right? So the vitamin D levels are going to be really anywhere. The number of patients that have undetectable levels of vitamin D, which at the university is like 13 and below, is really high. We're also very good at sunscreen because we've been burnt a lot and things like this. And so I think there's just a level of protection that just in awareness. I mean, the number of patients coming in, it's like I had the tingles, and I got an MRI to evaluate for MS, versus, in St. Louis, not to say that this was always the case, but like, a number of patients that, were wheelchair bound and somebody said, hey, you should maybe get an MRI to get that checked out, right? I can't tell you how many times that would happen. So I think that kind of talks a lot about it, right? Then the big walks, the awareness of everything, the hikes, all the educational programs such as this one, right? Just bring out MS into such an awareness. People talk about it and things like this, that it's getting diagnosed really early here.
Can I ask a follow-up?
Yeah.
Kind of along those lines, what about environmental factors in general? Have there been any studies?
Yeah, so the interplay between environment and genetics is an important one. So I'll use vitamin D as an example again. So promoters are areas in the gene that help drive expression of that area. And some of the genes associated with MS have a vitamin D promoter. So the higher the levels of vitamin D, the more you would run certain genes or maybe shut them off. And so that's a little bit of that interplay that we see between sort of the environment and the genetics of it. There's been a lot of discussion about Epstein-Barr virus. I'm not sure that I'm a believer quite yet for it for a number of reasons. One is Epstein-Barr is a very common virus. And I've seen a lot of patients with those monophasic events that got infected with known other viruses, and sometimes that happens. Guillain-Barré is sort of like that first time event of the peripheral nerves. We can have similar events sort of in the brain. That goes by a really long name that we abbreviate called ADAMs, but it can be bacteria infection, virals, and all that kind of stuff. So I think there's a trigger that has to be an infection probably. Sometimes we know what that is, sometimes we don't. It might be more common with certain things like Epstein-Barr virus. That triggers the immune system. And then things like smoking, which we know increase the risk of developing MS and more progression, more disability, can then lead to more issues as well as developing MS. So that probably keeps the inflammation at a higher level. It doesn't let it shut off. So it becomes a one-time event, it becomes a recurring event, and then it becomes this multiple sclerosis phase to it. So some of the big ones, again, tend to be, the thought around viruses, particularly Epstein-Barr virus, low levels of vitamin D, smoking, but there's like a handful of other ones that have been kind of linked as well.
On the genes and vitamin D, is there any vitamin D connected to genes? I struggle to big doses of it, and I still struggle with it.
Yeah, there's also, so I think some of the genetics for this is sometimes the absorption, but it's also how fast you break it down and things like that. And so to some extent, it's easy to just take more vitamin D. I don't think sometimes it's worthwhile spending more to get a vitamin D. Some people just take 10,000 units a day. Some people can get away with 1,000 units or sometimes none at all, and their levels are fine. So it's probably a little bit of that combination of either converting it a little bit easier from the stuff we absorbing it more, or degrading it.
We had another question from online asking about the TENS units, the nerve stimulators. Do they help with MS foot drop?
Yes, so perfect. So a lot of questions around kind of spasticity, foot drops, and things like this. So around foot drops, and just I would say leg weakness, there's a question about why does MS cause a lot of leg atrophy? MS causes a lot of atrophy wherever it affects it, because if it causes weakness, you get atrophy associated with it. It tends to be more legs than hands, and it tends to be very specific patterns. So we call the spinal cord in the brain upper motor neuron, lower motor neuron are the peripheral nerves. When you look at upper motor neuron disease, which is what MS would do, it causes weakness in the hip flexor, so lifting the knee up. And at the foot, it tends to be the problems with a foot drop, so keeping your foot up so then it drops. So those tend to be kind of the pattern that you can kind of see. So those are the two big muscle groups that you'll see affected. So if you have whichever one affected, then you'll see atrophy associated with it. If it's one-sided, you'll sometimes see a difference in size in the calf muscle, for example, and things like that. Calf actually pushes down, but they kind of more the side and the front that helps you kind of lift up the foot will help with that. So sometimes that is weakness because of tightness, so spasticity, because you're kind of fighting a force that's trying to kind of keep it from moving. So a relaxer can help with that. So from a drug perspective, if you're very tight, muscle relaxers can be helpful. Baclofen is a common one that we use, but you can use any one of them. It just probably has some of the, this is hard to say, less sedation, because they all cause a lot of sedation, including baclofen. But tizanidine or Flexeril are two of the other ones that we will use. There's some new ones getting studied now. cannabis is the other one that sometimes it's, that we can kind of explore and talk about and people try, and it can be helpful for spasticity. The other drug that we tend to use is Ampere or Amphetamine. That one works a little bit by increasing stamina. So through areas of the nerve that have lost the insulation, that myelin, it helps conduction through those areas so it doesn't peter out as easily. And so that drug can be helpful. It might increase, being able to walk 2 blocks to walk 3 or 4 blocks. It's not a miracle drug, but it can increase sort of how far you can kind of go with it. When nerves work a little bit too well, the concern becomes seizures, so you have to watch out for seizures. So if you've had a seizure in the past, we can't use the drug. So those are 2 big groups that I would say we use for that. And then the other thing is devices, and this is an area that has really kind of changed a lot. There are kind of nerve stimulators, so things that stimulate the nerves. Those have been around for a while, things like Walkaid and Bioness have been around for a while. They were really expensive. Usually they have to be programmed by a physical therapist. So a little bit more challenging. You have to buy it before you try it, those kinds of things. The other one that's kind of been a little bit more recent has been sort of these muscle stimulators. So Cyonic make one called the NeuroSleeve. For full disclosure, I'm on their scientific advisory board. That has some pads, and it can actually get the hip flexor a little bit. Some people it doesn't work. The sleeve is too small, too big, so you have to kind of be in the right size. And the pad, it can be a little bit of a pain to put on because it's kind of this Velcro thing, and you got gooey pads that you're kind of trying to slap on, both in the lower leg and the upper leg. So you're kind of slapping this thing on. But for some people, it does allow sort of a big difference, and then you can program it yourself, which is kind of a nice thing. So there's a lot of devices kind of coming out. I think from the other one is the fixed devices that are often used, like AFOs, so ankle foot orthoses. Those are the ones that you'll often sometimes see that kind of go into the shoe and wrap up the calf. Until there's a little bit better ones with carbon. They're kind of custom molded and things like that. The ones recently that have had kind of good luck for people that don't have a lot of turn in their ankle. So a lot of times because of that spasticity, instead of being able to kind of be flat with your foot, it starts to turn and you start to walk on the outside of the foot. If that's the case, then you almost need a solid AFO that will keep you flat. But there's some that kind of wrap around your ankle and then will hook into little hooks on your shoe that can help you, and you can adjust them. So it allows you to get to a certain point and stop, but it gives you flexibility to pull up some. So you can kind of still use your ankle and it doesn't wrap around the calf, so it's a little bit more comfortable and things like that. And there's a couple of different companies that do that. If you do look at those, there's some that are really cheap online, just as an FYI. Look for ones that hook in farther out in the shoe. Because if they hook in really close, it loses all the leverage and they don't work very well. And those can be as little as like $20. Those aren't worth it. It's just an expensive shoestring if you want to use it that way.
On the like the sciatic sleeve.
Yeah.
I tried that. It made an amazing difference. And I am getting one. Can connections themselves
It
and
can.
help reduce the muscle atrophy.
Yeah, they're so new that I'm not aware of long-term data, but they're working on some of those studies to kind of collect that data. One of the impressive things and one of the reasons for working with them is that they can collect a lot of data. So they measure number of steps, but also like strength on pulses and all this other stuff that I don't have a clue what they're talking about for the most part. But because they can measure that stuff. And one of the things is because you do use the muscle, right, then it allows you for exercise. When you immobilize them with like the classic AFOs, then you don't use it and you lose it, kind of in a sense, right? So given the option, I much prefer those devices that allow you to actually keep the muscles active.
Is foot drop and muscle atrophy common in pediatric MS?
All right. Seems like an easy question, but it's a complicated one. So yes, the thing is kids tend to bounce back better than adults, right? They have a much more resilience than adults do. So it depends a little bit on the question, or how you ask the question, I should say. If you say within the next 2 years, 5 years, who's going to develop more atrophy, more weakness, then the answer is going to be the older person. If you say by age 60, who's going to have more weakness, somebody who's had disease for 5 or 10 years is going to be better off than somebody who's had disease for like 50 years. So that's a little bit of this issue when you hear about like, oh, it's good to have MS diagnosed when you're young. No, it is not, because by the time you hit older ages, you've had MS for a really long time, and it is not a good thing to have MS for a good time. Sorry, a little complicated one.
I'll just give a little plug here as well. The next issue of Informed magazine that comes out will be on pediatric MS. So if that's a topic that interests you, you got about a month to wait.
I'll do a couple of quick hitters as well as I got to run through the list. There was a brain shrink twice as fast in the general population. Is there anything we can do? So brains in MS will shrink if there's disease activity. If you control that disease activity and it looks like things are stable, then the atrophy is the same as normal people. And we did some studies when I first got here that compared Tysabri healthy controls. They looked the same. Compared, fingolimod or Gilenya to Copaxone, looked exactly the same as the healthy controls, the same as the Tysabri. So if your disease is controlled, and it looks like the general population. Where it gets debated a little bit is around progressive disease, where you can have a little bit of an increased risk maybe of progression, but even that is a little bit kind of plus minus, and those differences are so tiny that it is hard to kind of compare those changes. People who progress faster tend to have more atrophy. People who have inflammatory disease activity. So this is why my first concern is relapses. People with relapses will lose 2 to 3% of their brain volume. With chemo will take out 2 to 3% of. You tend to lose about 0.25% per year in the general population. If progression increases it might be 0.4%. Okay, so number one priority is take care of that relapsing disease, because that's where we see the big changes in the brain volume when we do see those changes. Symptomatic stuff. Treatments for hand tremors. God, those suck. So there are drugs for tremors. It depends on the tremor. So things like essential tremor, we can usually try something called primidone or beta blockers such as propranolol. We try them in MS. They don't tend to work too well. There's a question around deep brain stimulation for Parkinson's disease. It works really pretty well for Parkinson's disease. It's worked for essential tremor. It's been tried in MS tremor. It doesn't tend to work very well for MS tremor. So when there's progression, in most patients, we talk about progression from a weakness perspective. That's most patients. There's a small percentage in the order of single digits, maybe 5% of MS patients that when they progress with incoordination and tremors. And that is by far the worst, because a little bit in changing in coordination means that you might have the strength, but all you're going to do with it is fling that spoon when you're trying to feed yourself, because you can't put it in your mouth. And so you end up seeing people not being able to walk as well and things like that. So those are the ones that tend to scare me a little bit more for that. We still try those things. There are some tricks. If you're still strong, you can do weighted balance. So sometimes you can put weights around your wrist or your ankles to kind of just, so instead of having that big amplitude to the tremor, you can kind of make it smaller and help coordinate things a little bit more so. And this is like one of those things where we go to the experts and other people, right? And we can go to like occupational therapy for hand function, physical therapy for legs, and they have some other tricks. So things like spoons with bigger handles and things like this, little things that maybe sound kind of dumb and wouldn't change much, but they allow the difference of feeding yourself versus not feeding yourself and can make a huge difference. So, so we use those resources a lot for some of those patients. Let me know if you got anything else coming through. Nothing? All right. So I got a question about Octave biotest or blood test. So Octave makes a panel of biomarkers that you can use to look at. Initially it was for diagnosis and now for monitoring more so. And it includes some of the usual suspects, neurofilament light, GFAP, and then include several other things. It's okay. I'm not a huge fan. I don't know how to use NFL. I don't know how to use GFAP in MS patients. They might have some roles in certain positions, but I think MRI gives us a lot better of a marker so far. If you're not able to do MRIs as often, blood tests might give us a little bit better sense. The problem with blood tests is if you have a relapse, we don't know how high up your NFL needs to go or these markers need to go to be considered a relapse, how long to stay up, which is important because, you know, if you're trying to monitor somebody, do you need to do the blood test every week? Is it every month? Is it every 6 months? So those things matter as far as trying to understand that. Versus a lesion stay 5 years later. So if there's a permanence to it on MRI that if you're on high efficacy drug, those may see you and they put you on a high efficacy drug because the drugs work really well. The blood test might be a little bit more of an issue if you're on a drug that's maybe a little bit less efficacious and then might detect a little bit of ongoing inflammation and things like that. They don't have a test for progression, which is the problem. They're working on it. So from a relapse perspective, I think it measures a lot of the same stuff we already measure with some of the other things that we have. You'll hear about like there was this one time where it was helpful. When I got 1,000 patients, if it's going to help one person, I'm not sure it's going to be something I'm going to adopt very widely. So that's my concern around that. They're doing certain cases like will help us try to tell the difference between a relapse versus pseudo-relapse and things like that. Possibly they haven't done those tests, so we're working, you know, we're suggesting those tests for them to do, potentially helping with them a little bit.
We did have a question online. Is there a correlation between the frequency and number of relapses since diagnosis and the severity of iris when changing from Tysabri to Ocrevus?
So iris is not a thing when switching. Iris is a thing when you have PML. IRIS stands for immune reconstitution inflammatory syndrome. So basically the idea is you've blocked the immune system. It's allowed that virus that now likes to get into the brain, cause PML. This infection's going kind of rampant. Now you take away the drug that allows the immune system now to go. But sometimes the body gets a little bit overzealous. And so when it does that, it can cause a lot of inflammation because now it can really go in and cause all this swelling and other activity. And so we can see it actually starting to enhance and swelling and things like this. So then we have to treat it with steroids to try and lower the immune system to try and find that right balance. Usually happens several weeks after the immune system is ready to attack the virus and things like that. So iris will occur in that setting, not with that switch, unless you develop PML. I forget if there was a first part to that question about iris. Okay, cool. The role of AI. I mean, for somebody who just started to use, ChatGPT a couple of weeks ago, I can tell you that yes, we're starting to use it. Still trying to figure out how to use it and all that kind of stuff. I mean, drug companies have been using it for a while. It's been used on large data sets to try and say, hey, if we put all these MRIs in, can you predict, which patient is progressive and which one isn't? It tends to pick out a lot of the same stuff we would have said before. That brain that's shrunken down like a nugget probably is going to be progressive. The one that looks really healthy and full looks really well, and things like that. The ones in the middle, yeah, maybe AI does better than we would otherwise do. It's, I think, helping pharma companies try to be a little bit more efficient in targets that they go after and things like that. But I think otherwise, it's a little bit, not mainstream yet as far as I'm aware of. But you do see a lot of posters and presentations about, we used AI to try to figure something out. And that's kind of where we're at with it.
What about diagnosis, specifically in AI?
There's been a lot of look at some of the data sets to see what's the ideal number of lesions and things like that, better than somebody who's seen a lot of MRIs to kind of pick them out and kind of suggest that stuff. You guys have nailed all these. Holy cow, let's see. Oh, COVID. How could we forget COVID? Yeah, it'll be interesting to see what happens. You might have heard that there's a lot of hesitation around mRNA vaccines with our current, it's hard to call it leadership. So if you don't believe in data, I guess you can make up anything you want. mRNA vaccines did not occur during the pandemic. mRNA vaccines were in development for a decade prior to COVID being a thing. So there's been, these were prime time. They were ready to find a target that they could kind of go after. And, to some extent, the COVID pandemic hit at a time where we were ready to kind of come up with these vaccines much quicker than they were. If you have concerns around mRNA vaccines, Johnson & Johnson's vaccine is available. It uses the old technology. It is not as effective. So the idea of trying to find, there's been a lot of push, for example, of defunding vaccine research into the flu vaccines and trying to kind of find a universal vaccine to take care of all flu so that every year we don't need to do that. That's been a thing for decades and it hasn't succeeded, but happy to at least try again if they want to fund that. And the issue that we got away from those kinds of vaccines was they tend to use the whole protein, all the proteins in these vaccines. The more stuff you can react to, the more likely you are to have reactions. And that's exactly the findings, is that whole virus vaccines tended to not be as effective because you're having many different targets, but you were also more likely to have reactions to the vaccines. So they've been cleaner, kind of the narrower you can kind of pick it out, and things like this, and the stronger you've been able to make the vaccine against very specific targets that you can identify, to kind of go after. So from a vaccine perspective, I think they will be available. COVID hasn't mutated much over the last 2 years. So even the old strain of COVID, I think will be, meaning even if they don't come up with a new one this fall, I think it'll be fine. The reason we need the yearly flu vaccine is because that virus keeps changing. And so you need to keep changing the vaccine to kind of go with it. So it allows you the COVID vaccine, it's probably going to be okay to it. The concerns, right, are a little bit around sort of if you're immunosuppressed and you don't mount as good of a vaccine response. The reality is we've seen pretty good T cell responses, so not the ability to form antibodies, but this other type of immunity through another type of cell called the T cells, so that with most drugs, and that includes B cell depleting therapies, those T cell responses are still pretty damn good, even if you don't have the antibodies against whatever virus you're trying to kind of test out for. So I think the flu will be available. It should be available, by the way, we're looking at pretty damn close, right? So like in the next couple of weeks, probably be available early September. The COVID vaccines, if you respond strongly to them, it implies that you're mounting a pretty good immune response. So maybe that's your good luck charm of saying like, I'll put up with the symptoms because I'm responding to it. I'd be more concerned if you don't respond to the vaccines. It's possible that you're not responding to your third and fourth vaccine because you've responded to the other ones, and so you've kind of gotten used to it a little bit. That is a possibility as well. And so if you're, I think this idea of needing them every 6 months, every year, probably is starting to kind of wane out. Now, things I would watch out for is if the numbers really start to spike, it says probably that the virus has changed. So I'd probably get vaccinated again at that time. Or if we start talking about, the Zulu variant or whatever comes up next, I think otherwise, the other piece that we can do are the monoclonal antibodies that can let you form a good response. So if you've not tolerated infusions with a new kind of, so I think sometimes called Evusheld 2.0, but those are kind of the things where you can get, sort of these antibodies that are preformed for it, that you can then, provide that immunity. Not as strong as your own immunity, because that doesn't give you the T cell response, but it will give you at least the B cell response by making antibodies. So hopefully those will continue to be available as needed. And we'll see, and we'll probably have some update on this probably around at the Ed Summit would be my guess, to see where we're at.
There are 2 minutes from finishing.
How do I want to word this? So I've heard, like I have seen in a lot of my MS groups discussions that they were going to change the protocol or requirements that you have to be able to get the COVID vaccine. Do you know anything about that? Is that true? And if so, are we going to be included anymore?
You know as much as I know,
Okay.
unfortunately, because it's been such a moving target. I mean, I'll just stop there.
Okay. Fair.
Every other day they're coming up with new guidelines and changing what they think and where they're going with stuff. So it's hard to kind of predict where they're going to come out with it. One really quick one, there was a comment around ultraviolet light in Scientific American June issue of just this year. I don't know much about it. I think it falls into the category of, I've seen it, there's red light therapy that, some patients will talk about. I think these all fall into the category of probably like really safe things to do. And if you find it helpful, do it. But the amount of data available on MS is pretty small. Even blue light data, it really may not be as bad as it is. And for some people, it's actually helpful for help, as far as falling asleep and how much it interferes with your cycle. Again, I think these are the things where, like, as a doc, I'm supposed to tell you need to sleep regular hours, you need to go to bed at a certain time every night. It's very important, and wake up at the same time every morning. I'm not wired that way. I do really well by sleeping, big nights and then having some really short nights. That's the way I work. I work well by falling asleep to TV at night. It puts me to sleep like a baby. You can ask my wife. One commercial and I'm out and out. So I think those are the things you have to play and just kind of know yourself and kind of know what works for you, like a lot of these other things, right? And just kind of see where to go with them.
All right, and that is all that we have time for tonight. So thank you again, everyone, for your many, many great questions. Thank you, Dr. Alvarez, for your time. We have evaluations on the table if everyone could fill one out, or the link will be in the chat. Those really help me shape future programming. And then I did want to share a couple of resources that I thought of while we were talking. Our last education summit in April, we talked a lot about the potential new criteria that Dr. Alvarez started with. So if you want to go into more detail about that, you can check out that presentation. And all of these are available on our YouTube. If you are interested in more of the family planning aspect, we have at least one, maybe a couple webinars from Dr. Anna Shaw. And so you can just search her name on our website. Summit, we did a presentation on brain atrophy. So just a reminder, if there's topics that you're interested in, please be searching our website and YouTube for more full-length webinars and things that we've done. If you're questioned at a previous conversations event, so if you go to YouTube and you search for conversations on MS, you can see a whole playlist of past events, and they have a clickable index of questions. So you don't have to listen to 90 minutes of it. So just wanted to throw those reminders out. And then our next conversations event is with Dr. Ellie Wade on September 17th. And our next education summit is November 8th.
So just as a plug, Ellie Wade's our new faculty member. Today was her first day as a faculty member. She was our fellow last year, so you can come and meet her then. The other question, and I think really the only one we didn't get to out of these 3 pages, was around stem cells and CAR Ts. And that was in spring last year.
Yeah, we have a couple of resources on the stem cell topic. We have one from Dr. Amanda Baquet, one kind of with some of the dangers, the warnings of the misuse of stem cells with Dr. Andrew Wolf. And we have several issues or articles in Informs magazine. So if you're interested in stem cells, I would search the website for that one. You're going to get the most robust response there.
All right, thank you very much.